Hi, my name is Ron Blankstein. I'm here at the AHA, and it's a great pleasure to speak with Dr. Pam Douglas, who just presented the PRECISE trial, a very exciting trial. Dr. Douglas, tell us a little bit about why it was important to do this trial.
There are a couple reasons that made PRECISE important. The first one is that guidelines recommend goals for testing, including deferring unnecessary testing or less testing, having a higher yield, fewer complications and costs, and of course guiding preventive medication. But they don't really give us a concrete way to accomplish this. I mean, there's no class 1 level of evidence, A, randomized trials to say this is how you accomplish these goals. And so we sought to pull the information out of the guidelines and put it together in a precision strategy, which has two components that reflect, real-world decision-making around testing for stable chest pain patients. And so that precision strategy, our intervention arm, consisted of a quantitatively determined risk by using a validated risk score, the PROMIS minimal risk score, for those at lowest risk, 20%, in whom we deferred testing. And all others, the other 80%, got coronary CT angiography with selective fractional flow reserve by CT.
Well, what were the findings?
Well, the findings surprised us and excited us. There was a 65% reduction in a primary endpoint that was a net clinical effectiveness composite of death, myocardial infarction, or cath without obstructive coronary artery disease. Now that last part, the cath without obstructive coronary artery disease, has been an endpoint in other trials in where it's been found to improve quality of life. A lower rate of that would associated with a higher, better quality of life, less costs and less complications.
Yeah, and I think it's a relevant endpoint because it, of course, has economic implications, but it's also an endpoint that our patients care about.
Yes, I would,
So,
and you, I think, would join me. We don't really want to have that cath. That isn't necessary.
Yeah. Share with us, how often was FFRCT actually used? It was available to the site, so it was up to them to decide when to use it. How often did it end up being used, the FFRCT?
Yeah, so we recommended but did not require that in the precision strategy arm, those who are having FFRCT, that they send for FFR information anywhere between 30% and 90% lesions. So perhaps a broader range than usual. So it was used 41% of patients had it, and this was almost all of the patients with lesions that were between 30 and 90. So it's a little higher perhaps than we see in clinical care, but I think that's related to the broader criteria, but also because we removed 20% of the patients in the deferred testing arm who didn't have a CT, which concentrated the disease in those who did have a CT.
Well, let's talk about the deferred testing. I think that's a really important part of this study and a very interesting one. It's, of course, something that we covered in the recent chest pain guideline, how to avoid testing in low-risk patients. Why is that deferred testing only applied in the PRECISE arm of the trial and not in usual care?
Well, we really wanted to do a randomized trial of deferred testing. The guidelines, recommend this, but they have several strategies that they propose, and none of them were in the form of a formal recommendation. Use this one. And so we took one of the ones that's recommended by the guidelines, the PROMIS minimal risk score, and applied it only in the precision strategy patients, but we stratified our randomization by risk score. So we essentially have a nested trial or trial embedded, a randomized trial embedded in PRECISE of deferred testing versus usual care testing. And this, to my knowledge at least, is really one of the first times in cardiology that we have a randomized trial of doing less. And so it's pretty exciting to be able to do that. And importantly, we found that there were no events in no deaths, no MIs in the group that were assigned to deferred testing. So we felt it was both safe and efficacious, and the primary endpoint was positive in that group as well.
Yeah. So maybe something we'll be using more in the future, deferring testing. Of course, not just in patients referred for CT, but I guess we can apply this to other non-invasive testing strategies in the future.
Our patients were randomized to CT or usual testing, so it would apply to everybody. I think doctors all know that, when they order a test, this one's really unlikely to do it, but we don't have the support to say somebody has tested this and we have an evidence base to say that this is safe. And that my patients aren't going to, walk out of here and have a heart attack, because we worry about liability, we worry about missing something. And now we can say, you're okay. If you use this risk score, you'll be okay.
Let's talk about medical management. That's something that I'm always very interested in, how testing influences patient management. In a trial like this, is management something that's up to clinicians to decide, or was this actually dictated as part of the protocol for the study?
Yeah, so we had a very pragmatic design, which the only thing the trial stipulated was the initial evaluation. We didn't stipulate which usual care test. If you were in the usual testing arm, which you would have, we allowed all of them, including cardiac catheterization. Nor did we stipulate anything about preventive care or anti-anginal treatment after the testing, or second testing for that matter. And we let that be the province of the treating physicians, whatever they thought was appropriate, rather than dictating something to them. We did say you should follow optimal medical therapy. We gave them handouts and stuff like that, but we didn't insist on it in any way. And what that allowed us to do is a couple things. First of all, it made it very easy to participate in the trial. And so it's more generalizable. But it also allowed us to track preventive treatment and whether it was better in one arm or not. And as it turned out, there was greater use of lipid-lowering medications and of antiplatelet agents in the precision strategy compared to the usual testing arm. And the magnitude of that change was about what we reported in PROMISE and about what was reported in SCOT-HEART, which of course drove the very positive 5-year results in SCOT-HEART in favor of CT.
So I think that's interesting, because the outcome that was changed in this trial really was driven more by patients who went to the cath lab who did not have obstructive disease. Medical management, on the other hand, may have some benefits down the road. We saw this in SCOT-HEART, that it actually takes some time before you start to affect that. So do you think those changes may have some implications for the future for these patients?
I hope so, yeah. But I don't know. This is we had a 1-year duration of follow-up. We would love to get our patients together and find out what's happening to them 5 years down the road.
So we have a trial that I think will change practice, but we always have to think, what patients is this most applicable to? So which patients that we all see in our practice are these results applicable to?
Well, I think they're applicable to the folks that we enrolled, and so we wanted stable symptoms. These aren't ER rule-outs. These are stable symptoms, suspected coronary artery disease. Our population was a very middle-of-the-road angina practice. Mean age 58, half women, 94% had at least one risk factors, 25% had typical angina. I mean, you probably see these people in clinic every day, every week, and need to make decisions about what to do with them. So I think it's very generalizable, and because it's pragmatic, very real-world results.
Okay. Well, thank you very much, and I want to congratulate you and your entire team on conducting a very important trial for the field.
Thank you so much.